So good evening, everybody, and let's talk about cardiopulmonary bypass. So we have a perfusionist amongst us, so for him it might be familiar, but for the rest of you all, if you have an interest in cardiology or cardiac surgery, then this is going to be an integral part of your work life. So when we operate on the heart, we need to stop the heart so that we can go into the chambers of the heart and repair it. This is especially true of pediatric cardiac surgery. So if we need to stop the heart, then somebody else or something else should take over the function of the heart. So the heart in isolation will not be stopped. It will be stopped along with the lungs. So hence the word cardiopulmonary bypass. So we need to bypass the function of the heart and lungs so that a machine takes over the function while as a surgeon we can operate on this heart, knowing very well that the rest of the body is perfused adequately with optimal oxygenated blood. So a little bit about the history. So the first operation was performed using this cardiopulmonary bypass on the 5th of April in 1951 by Dr. Clarence Dennis at the University of Minnesota. But this was experimental and not on any human. So the first successful open heart procedure on a human being using bypass machine was performed by John Gibbon. And this happened in 1953 in Philadelphia on the 6th of May. So he closed what is called as the atrial septal defect on an 18-year-old child. This is something very interesting. So the picture you see here is of Walton Lilhay. He's a very famous cardiac surgeon. And he did something called as the controlled cross circulation. So to the right of your screen, you see that there are great vessels, the iliac vessels, which are sutured to the vessels of a child in the neck. So based on the placental function and what we call as azygous flow principle, he connected the father of the child to the child who needed the surgery. So this heart-lung machine, which was still in progress or evolution at that time, Sir Walton Lilhay decided to use the donor or the parent to act as this machine while the child's heart and lungs can be stopped, and then he can operate on this. So he said that probably this is the only surgery in history to have chances of 200% mortality because 2 lives are involved here. He operated on 45 patients between 1954 and 55 using this technique. None of the donors had any morbidity or mortality, and he had 28 successful surgeries. He operated on kids even with tetralogy of Fallot using this principle. So by definition, what is cardiopulmonary bypass? It's a form of extracorporeal circulation. That means it's outside the body. And it temporarily takes over the function of the heart and the lungs during the surgery. So we can maintain the circulation of blood and oxygen content of the body. So as you can see, there is the heart, and what is in red, you take it out, and what is in green is also coming out. So essentially, we connect the heart and of course the lungs to this machine where you can see the blue blood coming out of the heart, and then that gets filtered and gets converted to red blood, and it's given back into the aorta so that it goes to different parts of the body. So there's a pump involved in this, hence the cardiopulmonary bypass is called as a pump or the machine, cardiopulmonary bypass machine. So in short, it's diversion of flow of blood from the aorta via a pump and an oxygenator, and it will avoid both the heart and lung being functional at that point in time. So like I said earlier, why do we need it? We need it because we need to facilitate surgical intervention. We want a bloodless field and we want a motionless field. So to achieve that, we put the child or the patient on cardiopulmonary bypass. So who all will need it? Anybody, not everybody with coronary artery disease, but most patients may need the cardiopulmonary bypass if they're undergoing coronary artery disease, especially if it's associated with a valve repair. Most congenital heart defects will require cardiopulmonary bypass, aortic dissections, aneurysms. Sometimes when you're transplanting the liver you'll need it, but otherwise for the heart and lung, you'll definitely need it. And when you're operating on maybe cancer surgeries on the renal or limb, because of the involvement of the IVC, we may need to put them also on bypass. But most commonly, I would say that you need it in congenital heart defects. Also, hypothermic rescue, that's interesting. If somebody has gone into severe hypothermia, we can put them on bypass and rewarm them, the core back into it. So coming to physiology, these are some of the fundamental things that occurs, or the physiology that a patient undergoes when on cardiopulmonary bypass. One is hemodilution. We need to thin the blood. Next is anticoagulation. We should make sure that the blood does not clot. Third is hypothermia. That is, we need to cool down the patient to various degrees depending upon what type of surgery we are going to do. All this, of course, we need to monitor the flow rate and the blood pressure. And we control the blood gases. That is the pH of the blood, the PCO2, the PO2 levels, the bicarb levels. All this is very, very acutely controlled by the perfusionist. This is a picture of how the cardiopulmonary bypass machine looks. On your extreme left, the big box-like thing is the hemotherm, which helps to cool or warm the patient and the blood. The next one is the cardiopulmonary bypass, a lot of tubes. Individually, I will explain to you what are the components, but generally this is how big the machine looks. And then it gets connected to the patient, where on the other side, you see the operating team, we are operating there. So what is the goal of cardiopulmonary bypass? We want to oxygenate the blood and we want to remove the carbon dioxide. We need to keep the blood circulating according to the demand of the patient at that particular temperature at which we are keeping the patient. We need to systemically cool the patient and we need to rewarm the patient back to their normal temperature. And of course, we need to divert the blood from the heart in order to provide a bloodless surgical feed.